Okay, well, welcome virtually to GW. Our speaker today is Professor Lara Jehi from Cleveland Clinic. I'm very delighted to introduce her. I was fortunate enough to be her classmate in undergrad and medical school. Lara then went to Cleveland Clinic for her training in neurology and epilepsy and has become one of the world leaders in studying outcomes of epilepsy surgery, and she's published her papers in the most esteemed journals and has secured extramural funding for her research on finding algorithms to predict outcomes. Lara is currently the Chief Research Information Officer at Cleveland Clinic, among numerous other accolades that she's secured during her career. Without further ado, Dr. Jehi and Epilepsy Grand Rounds.
Thank you so much, Muhammad. This is it's bittersweet to see you over the screen like this. I so wished we could be together in person. Dr. Kubaisi is a dear friend, and every time I see him, you know, that brings back such good memories. So let's move on now to the talk. John told me I should share my screen, right?
Yeah, please share your screen.
Okay.
And I'll make sure your video stays up.
Let me go back to the first slide. Okay, now can you see it?
Did you share screen from Zoom?
Yes.
We're still just seeing your video, your webcam.
Share.
Okay, there we go. We're seeing your kids.
Okay, how about now?
Yeah, relaunch your slides. There you go. There we are.
You done?
Yep.
Okay. I guess Zoom was taking a second. Okay. So we will talk about algorithms in clinical practice. Can they help us predict outcomes? And the outline of the talk, we will first start by defining what's an algorithm. Then we will talk a little bit about why do we need one and how can we use it. So let's start first with the definition. What is an algorithm? The definition is a step-by-step procedure for solving a problem or accomplishing some end. So this is the definition that's given by the Webster Dictionary, so I guess you should believe it. And the key words here are bolded for you. So it's a step-by-step procedure, and there should be a problem we want to solve. And all of that should be towards getting to some end that we are working towards. So say the end to be accomplished is getting to some exotic place. When I prepared this talk first, I was thinking of Bangkok, Thailand. You know, I thought that's a hard trip to plan. It turns out Washington, D.C. was a hard trip to plan. And here I am doing this virtually for you. So I guess Washington, D.C. qualifies now and is up there on the list of exotic trips to make. So say this was the end to be accomplished, getting somewhere. The way we did that before algorithms were available is, I'm sure most of the people in the room won't even remember this, but for older people like me, back in the days when we used to want to plan a trip, we would have to go and find ourselves a nice travel agent, and we would use a lot of maps to find directions to where we wanted to go. And we would get travel guides and trip guides and, you know, books to read about how can we plan a nice trip. And, you know, we could even be drowning in books trying to learn everything we wanted to learn about our destination. How is it that we plan our trips now that we have algorithms that are available? We all go to our favorite, you know, travel airline website. We pick our date, pick our destination, and voila, we have our ticket. We map out the itinerary on the phone. We also go to our favorite website for things to do wherever we are, and we find stuff to entertain us. And if we're lost, we can always Google things, including Googling what is an algorithm. So we can talk about that with our colleagues. So if we had a different end, say the end to be accomplished is deciding epilepsy surgery management, whether that's in Cleveland, where I am now, or in DC, where you are. How did that practice evolve over the past 30 years? The way we did this 30 years ago is we would get together in a room. This is a picture from our multidisciplinary patient conference. You see the person talking here is Dr. Elaine Wiley, one of our more senior epileptologists, and we would discuss what kind of surgery to offer. And this is exactly how we do things now, still. The room changed, people got older, but it's the same practice. We still get in a room, sit together and talk, and that's how we make our decisions. Something is off now, so we use algorithms everywhere in our life, except at work, except in our case, caring for patients with epilepsy. It's like we're using a flip phone still at work. And we use this for the rest of our life. So how do we do algorithms in epilepsy? We don't really, for the most part now. We rely on our gut feelings. And we rely on knowledge, science, to make our decisions. But what we will talk about for the rest of this session today is how do we move from these gut feelings to evidence? And how do we do that in a way that builds the future of epilepsy surgery? We need to review, to find the place for algorithms. Let's review the current flow of a patient through epilepsy surgery. There's definitely many different steps that go there, but let's simplify them and put them in major buckets that we go through. So the first step is usually to find the candidates, right? We have to find the patients who may qualify for epilepsy surgery. Then we need to find the epilepsy in the brains of those candidates. Then we have to remove that epilepsy through surgery. And then, voila, we do all of this, and what happens is we make a patient seizure-free. This is how our mind works when we are moving a patient through the trajectory of surgery. How do we find the candidates? There are many outcome predictors that have been identified that highlight different characteristics that would make patients good candidates for surgery, whether it is in the temporal lobe resections or frontal lobe resections or posterior quadrant resections. And this is definitely not an exhaustive list, and by no way try to read it. The idea from it is to just communicate that there are multiple outcome determinants out there that we use to various degrees in helping us identify who potentially could benefit from surgery. How do we find the epilepsy? We have also progressed a lot in our method to localizing the epilepsy. We do very detailed pre-surgical testing. We do a lot of imaging. This, for example, is a patient who has a cortical dysplasia. You see the transmantle sign there. On the flare, they have concordant SPECT and PET. imaging. We, the strength of our scanners is increasing. We started 1.5T, we're up to 3T, and now we're at 7T. The number of the T's keeps on increasing. We will be in the double digits pretty soon. We do a significantly detailed, thorough EEG evaluation, which could be intracranial, many electrodes as we want to implant. We're at the point where we can draw connectivity patterns in the brain. So that's a fairly sophisticated pre-surgical evaluation testing that can be done. And then removing the epilepsy, we have a lot of innovative surgical techniques now, whether it is with, neuroablation, there is work on ultrasound. There's a lot of innovation that is happening in that space. The decision, though, about after all of this testing and all of this investment into finding the epilepsy and getting the patient to the point of localizing where it might be, we get to that final step that closes the whole loop. The step where we distill all of that information into one final point, right? We have to point to the surgeon, sometimes even draw a map and say, this is it. This is what you need to cut. We have to be that exact, right? So that point where all of the testing has to come together to a final decision is the patient management confidence. And it still happens now the way it did 30 years ago. So maybe that's why this expectation of making a patient seizure-free is not where it needs to be. And this is the data that tells us that we are still not where we need to be. These are longitudinal outcomes of epilepsy surgery following all the major types of resections that we could do. This is it after posterior quadrant resections, temporal lobe resections, frontal lobe resections, as far out as 10 or 12 years after surgery. And you see that we are pretty much at around the 50% mark. So 1 out of 2 patients with drug-resistant epilepsy who has surgery becomes and remains seizure-free for a decade or later after resection. This is great when we look at it compared to the alternative of less than 5% of those folks would be seizure-free without surgery. So getting that 5% up to 50-55% is definitely a great thing. But, there's this other half that has remained uncured by surgery. We cannot say unhelped because we do reduce seizure frequency, but they're not cured. So why is that? Could it be because of this final step that hasn't evolved, So if we changed everything, trying to make this problem better, except for this one thing, the final decision point, and we are still not where we want to be, then it really begs the question of, are we not where we want to be because of this, one remaining step that we haven't evolved in yet? So let's get to the second question, which is, why do we need this algorithm? We have gone through major strides in our efforts to better localize and better resect the epilepsy. We started off in the 50s with people making decisions on epilepsy surgery just based on a scat EEG and the pneumoencephalogram. That's all they had. And over the years, we acquired the ability for stereotaxy. We had safer surgical techniques, better imaging, and now the list is infinite pretty much for how much testing we could do. With that, we are operating now on complex patients that there is no way we could operate on 50 or 60 years ago. But the proportion that is seizure-free is still the same. So, in a way, the fact that we are operating on more complex patients is sort of more than made up for by the luxury of having the additional testing that we have now that wasn't available in the past. And we are still in the same place. So let's focus on this last point of the decision making and drill down on the fact that all those decisions are largely intuitive. I have to say that when I first started talking about these challenges many years ago, the one common pushback that I would get, that I'm sure is in the minds of many of you listening right now, is that there's nothing wrong with this. We are smart, we are trained, this is our job. This is what we went to medical school for. This is what we did our fellowship for, and we've been practicing for many years, and that's all we see. So we are the experts, and we know what we're doing, and there is no better way of doing this. We know what the right choice should be. So let's test that hypothesis and see. We did that in this experiment where we took 20 actual cases from our program. Patients who had drug-resistant epilepsy were worked up, underwent surgery, and we know their outcome. And we presented each one of those 20 cases to a group of epilepsy surgery specialists from across the country. And we went through the presentation the same way how you would in a patient management conference, going over all the testing, the history, the evaluations, and then came up with a recommendation for what to reset. And the one common question that we asked each one of those 20 people is this: if you had 100 cases just like this one, how many do you think would be seizure-free in 2 years? Which is, really what the patients ask us when they see us after, for an evaluation for surgery. Hey, doc, do you really think this will work? Will I be helped? Will I become seizure-free with this? And what you see here on this line, so 1 is the case. This is case number 1. And here, these are the predictions that were given by each one of the doctors. There are no, this is not 20 predictions because some of them overlap, so you don't see 20 dots, but these are the predictions of the 20 physicians who saw this, who saw this case. And you see that their prediction for becoming seizure-free ranged from between 30% all the way up to 80%. So you could imagine if I was this patient and I saw a physician who fell in this group and they told me, I have a 30% chance of this brain surgery helping me, how I might be hesitant to have the procedure. But if I walk into this person's office, I'd be like, yeah, great, 80%. This is, going to work. I should definitely jump and have the surgery. So, when I would show this, then the pushback is, oh, you picked this case. This is one person who is very complicated. We all know these are these complicated cases that we can't agree upon. Surely it can't be this way for the majority. So then, How about the other 19 cases? This was their spread. So this is the same data, but in a more sophisticated, with more like complex stats thrown at it. What these are called, these are violin plots. So essentially each case is, the predictions for it are graphed where, this is the lowest prediction, this is the highest prediction, and the line reflects the middle quartile spread. And the color reflects what actually happened. So that this patient, the green people actually became seizure-free, and the white people did not become seizure-free. So, maybe in 1 or 2 cases, we had a spread that was close to about 40%, but for the majority of the cases, we were all over the place. Like, think if you were lucky case number 13, for example, and this is random, I didn't pick 13 to be, the unlucky one, but the prediction you would get would be anywhere from 0 all the way up to 90% seizure-free. So our predictions as physicians, as epilepsy specialists, had nothing to do with each other and had nothing to do with the reality. You see, there is the green and the white are equally spread with however the spread of the predictions is. And this is not unique for epilepsy. We are not particularly bad because this is happening to us. In all the fields of medicine, particularly those that deal with chronic disease that requires acute interventions intermittently, it is common knowledge that medical decision-making, when it's left to individual practitioners, is inaccurate. There is nothing unique about us because this is the way we perform. And it is because of the way that medical decision-making happens. If we are left, to our own devices to think about, talk to people, about lay people, about how we make our decisions in medicine, we think that medical decision-making is a logical and rational process. We think that the accumulation of knowledge, practicing for many years, improves the decision, and that past experience improves our current judgment, and that collective decisions are more reliable. That's why we get together in these groups, conferences, to be making those decisions. And to all of that, it doesn't quite work that way. And there are many problems for why it doesn't work that way. I'll just give you a flavor of a few of those. The first problem, there are multiple biases, multiple cognitive biases that interfere with the way we make our medical decisions. This is a table, so the fact that there is a 1 means that there is a 2 and 3 and 4. I think this book, this table goes up to 4. But anyway, these are some of the common ones that we see. So the availability bias. Who has not heard someone say in a patient management conference, I remember seeing a similar patient. I saw someone who was exactly like this. And that person had their epilepsy that was in their dominant insula. So I think this patient must have that diagnosis. Or anchoring bias, where from the very offset, from the first time we review a patient's records or we look at them in clinic, we form an idea in our head that this is what this patient must have. And then from that point on, every new piece of information that we get in our mind is weighed against this first idea that we have. It sort of has to fit it, or we have to force it to fit that initial assumption. Otherwise, we throw it away, or we downgrade sort of every other explanation that things can have, etc. You can read through the other biases that are out there. The second problem is one that is quite interesting. That one I found in a book about decision making in general. It had nothing to do with medicine, but I think it applies to us. So it highlights the importance of feedback in the learning loop. So it differentiates learning environment. So it talks about how there is a kind learning environment where the feedback of whatever step that we take is or decision that we make, that feedback is clear, it's immediate, and it is unbiased by prediction. So think of, say, the weather, for example. You look at a weather prediction for today, and it's clear. I mean, they even put it for us in pictures, right? It's either the sun, or there is rain, or there is snow. So it's clear what could happen, and we know immediately. We know in that day. We just look out the window and we see if that prediction is accurate or not. And whether the sun is going to come up has nothing to do with whether my phone said it should come up or not. So the outcome is unbiased by prediction. So in such a learning environment, models can be fine-tuned very easily, because you can tell right away if what you're predicting worked or not. So that makes it a kind learning environment. A wicked learning environment, the example that was in that book had to do with teaching, but I think our epilepsy surgery practice fits that model quite perfectly. The feedback is slow. If you remember these outcome curves that I showed you, at the beginning, sometimes our patients don't have their seizure recurrences until 5 months, 6 months, maybe 6 years after surgery. So we will not know until a while after we make that decision in our patient management conference whether we made the right decision or not. It's unclear. Patients come and talk about, oh, I'm doing great, everything is fine, but every now and then, maybe I feel a little bit off. Or so-and-so said I zoned out, but not really, I knew what was happening. Who knows if these people are having brief dyscognitive seizures, dialectic complex partial, whatever the nomenclature you want to follow is, or not. The main change because of prediction is an interesting one, but no, I have to say that having worked over medical charts and with physicians and with surgeons assessing outcomes for about 15 years now, it's interesting to see how all of these episodes are labeled as events of unclear etiology for years after surgery, or months, until the person clearly has a convulsion, and then there is no denying it, and then we say their seizures recurred because we did invest. I mean, face it, we did invest so much in making that patient seizure-free. It is really hard to say when they come back with these episodes that, well, maybe that surgery didn't quite work, and they are still having seizures. So we are in a situation where we are forced to be in this wicked learning environment for us to learn as much as we should from the decisions, our medical decisions, that we make in the context of patient management conference. How do we pick what to resect with surgery. What happens when the feedback is not immediate is learning gets impaired. The example that I find best to illustrate this is learning how to shoot a bow and arrow. If you are this kid trying to learn how to do this, and you're looking at this target right in front of you, and it's sunny outside, you see it very well, there is that bullseye in the middle and you want to hit it. You hit it, you'll know in a second you're there or you're not. If you're not, you know how to, move it, and you keep focusing, how hard you pull, your posture, how close you are until you get it, and you will get it. But if you get a bunch of your friends, a bunch of your epilepsy colleagues, and you all get in a patient management conference room, and you are all learning how to hit that bullseye of making a patient seizure free, except that you are doing it in this wicked learning environment where essentially you're shooting in the dark, and you won't know until months later if this decision worked or not. And you won't really all know, only the person who follows this patient in clinic will know, not everyone who contributed in that PMC will know. Then what will happen is you will start talking with each other, no? Like, we can't really see it, but then someone will say, I feel it hit it, I feel it worked, and others would like, oh really, so what did you do differently? And then they go, so move a little bit to the right, move a little bit to the left, and then they will all listen to each other. So they will all be throwing the arrow the same way, but what that does is it will make us more confident, right? We're all doing the same thing the same way, but this doesn't have much to do with growing more accurate, but we really don't know where it hit at the end. So we do things the same way, and that's how practice patterns emerge. This, surgery X becomes the best way of doing something, and it spreads, right? And we all do the same thing, but unless we know where we're landing, all we're doing is we're becoming more confident in something, and we're becoming more consistent with something, but this is unrelated to being more accurate at achieving our goal. The third problem, this is just me getting on my soapbox, which is that research and clinical care go in separate paths, and that is impairing our ability to learn. And this is not, some innovative thing that, I came up with. The Institute of Medicine talked about that many years ago, about how currently patient care is going along a linear path, from prevention, self-management, outpatient care, hospital care, and then follow-up, and the cost of care keeps on expanding, the complexity of care keeps on expanding, and along the way we have all of these missed opportunities to learn from each one of those steps of the care that we deliver. And what we really need is a learning health system where we incorporate research along our continuum of care, so we can learn from each care delivery that we perform, and ultimately improve care and deliver more effective treatment for our patients. So you see that there are many problems with the way we are making this final step of the decision, and that may be why we are not making patients seizure free. I mean, at least it's worth considering. We've invested so much into these other steps, so maybe at least consider that this may be an obstacle. So what should we do differently. How can we use algorithms in this final step? There are many examples of using algorithms, and one example of algorithms would be these machine learning models that are being developed in fields outside of epilepsy. So these are just examples of papers that were published in Nature Research, Nature Medicine, about how cancer screening has become improved, facilitated by applying machine learning algorithms to big data sets. There are emerging online prediction tools with major usefulness in epilepsy. So this is one that was developed by Lara Jehi and her colleagues with this online tool that they developed to assess the appropriateness for an epilepsy surgery evaluation. This is meant to be as a screening tool to potentially be used by community neurologists or people in privileged places where it can allow a course screening of who should be referred for an epilepsy surgery evaluation. This is another online algorithm, a risk calculator based on an algorithm that was developed from systematic review of published data, looking at the prediction of seizure recurrence after withdrawal of anti-epileptic drugs in seizure-free patients. And this here is the model that we published in the context of epilepsy surgery. This paper we worked on it more as a proof of concept of these initial two. This was one that was published before our paper. It wasn't really a nomogram, it was a model, but it was online. This came after. So we wanted to look at specifically the question of epilepsy surgery and see whether we can have a tool that allows individualized prediction, not us sitting in front of a patient who has temporal lobes epilepsy, considering surgery, telling them, 50% are seizure-free in 10 years. So that's 50% of everybody who had the surgery. The patient wants to know what are their, individual odds of becoming seizure-free. So we wanted to see if we can develop a model that does that individualizes the outcome prediction. And at the time, I had no money, so I couldn't ask people to send me a lot of data. So we only used 6 very basic clinical characteristics. And these were seizure frequency, gender, if the patient had convulsions or not, what the cause of their seizures was, and how long they had epilepsy for before surgery. And then each patient would get a score, based on their characteristic, and then you draw down the line from the total, and you get the prediction for 2 and 5 years. Nobody will do this. Nobody will draw lines and add up and come down. So we developed an online version of this where people could go to this site and just input that patient's individual characteristics and then click that submit button. And then you get an individualized chance of being completely seizure-free at 2 and 5 years and having an Engel score of 1 at 2 and 5 years. So if the model was completely overlapping with reality, with what actually happened, then the prediction would be along this diagonal line. So you see, we are not exactly over it, but we are very close. here and here. This is for the 5 years, this is for the 2-year prediction. But the confidence interval is fairly wide, which is, not a surprise considering that we were using, very coarse outcome measures. When you think back, when we say we want to do surgery and we choose what to resect, we use a lot more information than how old the patient is and how long they have epilepsy for and how often they see it, right? So this is what we're looking at now with the funding that we have. Is we are building the stepwise model where we are adding to these clinical characteristics all of the additional things that we look at in the context of surgery. So we're adding EEG, we're adding imaging, we're adding genetics, and histology, for path afterwards, etc. There are, since then, we've started building these algorithms and these nomograms for other questions that may be of relevance to us in surgical decision making. This is one that we published a couple of years ago, looking at predicting naming decline after temporal lobe surgery. And you see this one that even with just the course clinical and imaging characteristics, it did much better than the seizure freedom one. This is the ROC curve that looks at sensitivity versus specificity. So a perfect model would be one, where this line goes up, and there isn't much space that's left over in here. This is chance. So you see we are much better. The C statistic, I think, for this model was about 80-85% accuracy, which is pretty good. And this is, the manual version, but this is also available online. And that prediction was, we looked at 2 outcomes. One was, any naming decline, and one was just severe naming decline. We are building now one for memory decline as well as other, cognitive outcomes. So to sum it all up, I think that the future is not one where there is, we stop using our gut feelings or we stop using our intuition. Our intuition and our knee-jerk reactions for what should be done, they're unique to us. And there's something that we do acquire with all of our practice, and we shouldn't eliminate that. We shouldn't lose it. But at the same time, if I was playing Russian roulette and there were these, 6 places for that bullet, I think that before I shoot myself, I would want to know if there is 1 bullet or 2 bullets or 3 bullets or 4 bullets in that gun. I think that will influence my decision. And that is all what we say that using algorithms or taking a deeper dive into understanding our outcomes would do. Just that is telling us how many bullets are in that gun. They're not making the decision for us. It's just helping us make that decision. So with that, I would stop and just acknowledge all the people who have contributed to this work. And I so wish I was there with you because I take a lot from looking at the audience when I'm giving these talks. This is the first time that I'm doing this flying completely blind. So I hope that you found this useful, and I don't know if we can do questions. I hope we can do questions this way, but I I will defer now to John and Dr. Kubaisi for what I should do next. Thank you.
Any questions here? Yeah.
She can see.
All right. Thank you so much. That was it was very inspiring. The time you spent on the philosophy of justifying a scientifically plausible method of studying outcomes instead of relying on intuition or experience or the various flavors of different biases reflects the resistance that one faces when they want to change something that is folklorish or something that is prevalent in science. This is obviously also applies to other areas, but it's amazing to see that in science also, where logic governs and reigns, it's still the same as in other aspects of culture. So that was inspiring beyond epileptology. So thank you very much. Any questions from the room? All right, I guess you answered all the questions.
Okay.
I have one quick question. So your ongoing project will try to find an algorithm of predicting outcome. Is it based on prospective data from multiple centers within the United States and outside of the United States?
Yes.
Okay.
Yes. With this project, we have a partnership with Mayo Clinic from the States and with the University of Campinas from Brazil. And part of the model development is through retrospective data, so we're adding the EEG imaging and pathology and genetics. So all of that, we have several hundred patients that we included in the original paper where we didn't have any of that additional information. So we are looking at it and incorporating it. But then since we started, we've also been enrolling patients prospectively to look at things that we just didn't have in retrospective data. So special modalities of imaging, for example, that are not part of routine clinical care. So it's a mix of both deeper dive in the retrospective cohort and a comprehensive prospective look.
Terrific. Yes, we have one question.
You may have to repeat it for
Yeah.
I don't know if she can hear, but realizing that she's an epileptologist, are there other areas of neurologic practice she thinks are amenable to this similar type of approach? Disease process?
In neurology. Yes, the question, Lara, is are there any other areas in neurology that you think are amenable to a similar approach of studying outcomes besides epileptology?
That's right, algorithm or machine learning.
Algorithm, deep learning.
Yeah, I think everything. I mean, every...
Can we apply it to lottery?
I'm an outcomes researcher, so I'm biased that way, but at some point, it's, the outcomes work that I do here, I spend more time doing outcomes work for outside of epilepsy than I do inside. Pretty much any intervention that you do, looking at its outcome afterwards, it's a clear set of, it's a clear status, right? I'm doing something, does it work? And if not, why? Right? That's really the essence of all of outcomes research. So the something that I'm doing can be any intervention. And the fact that there is a lot of work going on in building algorithms now in imaging, in pathology, in cancer is not so much a reflection of the importance of the question to be asked as much as it's a reflection of the availability of data. So when there was a recent paper that was published, for example, about how looking at retinal scans and doing machine learning on them can help predict diabetic retinopathy and can help even identify, they could predict gender accurately just from looking at the vasculature in the retina.
Mm-hmm.
So, that got published not because, it's critical that we identify somebody's gender from the retina, but it happened because these procedures happen in the thousands, so when we say big data, it's big because it's available, right? So it could be analyzed that way. And then these algorithms can be developed. So in neurology, the challenge, one of the challenges for why we're not doing more of this, beyond all, the things that I mentioned, is just that in many of our individual specialties, we deal with rare diseases. Rare, in the big scheme of things, right? So we don't have, we're not hypertension, we're not diabetes, we're not these conditions where, half the population gets them, so we can have this, these large data sets that we can analyze. That is where we are challenged in neurology, but it's not that we don't have questions that need to be answered. Back pain, do you give them injections, or do you do surgery, or do you do therapy, right? Or take encephalitis and epilepsy, for example, cognitive decline. What is really the best way to treat? In MS, we have all of these medications out there. How do you start? How do you sequence? There are plenty of questions. The challenge is in finding the big data and curating it.
Sounds great. Yes, we have a couple of other questions.
Just have a comment. So, these online tools they potentially can help in underutilization of epilepsy surgery. They, outcome prediction or scoring and algorithms, which is similar to the ones that we have available in stroke, ChatGPT and Haslet. And I think that over time, it would just sort of help the utilization or increase the utilization of epilepsy surgery by making it sort of a little bit more straightforward and more applicable.
Dr. Seth, our colleague, is hoping that the availability of algorithms to predict outcomes will improve the utilization of epilepsy surgery, which continues to be underutilized despite a couple of decades after Class 1 evidence.
Correct. Correct. That's the hope. We hope that by demystifying that decision and making it more available for people, that neurologists who may be uncomfortable with referring could become, or that patients even, can have access to this and bring this option to their physician.
Alex?
Just a question from the epilepsy fellow standpoint. In surgery conference, I'm thinking about your research with opinions about outcomes and the opinions that were kind of on the fringe, like the 30% and the 80%. And I'm wondering if at Cleveland Clinic you can share any advice on how you approach soliciting all opinions in the room. Sometimes when you're the fellow and you present, you wonder if consensus doesn't feel that firm. You wonder if it's because there are opinions out there that just aren't heard, or if the case is really, that uncertain. From the maybe you could say the pure learner's standpoint. What do you do at Cleveland Clinic to help mitigate that?
You mean narrow the range?
Understand all of the opinions and take them all.
Okay. Well, Alex Andrews, one of our fellows, is asking how to understand the variability between the predictions of different faculty members at the epilepsy conference. So when he presents a case and one attending says the seizure freedom likelihood is 30%, but another says 80%, what are the clues, what are the tips for the fellow to understand the basis of these predictions by different people? Obviously, besides them, if we exclude the answer, in my experience, you know.
Yeah, it's really, I mean, you just listen to them talk. So, and everybody can build a castle out of thin cards, you know, with justifying why they think their opinion is the most accurate, you know. So the way it goes, I mean, every now and then you get these uncontroversial cases where everyone agrees that, you know, things should be done a certain way and it's going to work. But for the most, the cases that we seem to be getting nowadays are fairly complex. You know, these non-lesional cases, things are coming from everywhere. Who knows, you know, what's going on. And then if you have a big group, you know, like, so at the clinic there's about, you know, 12 of us epileptologists, and, you know, we have the surgeon. So you seek everybody's opinion, which we always do, then everyone starts justifying, you know, why they think the epilepsy is in a certain place and, you know, why that surgery will work. And they'll come up to, we need to do X, and I think, you know, it will work. Then 2 people down the road, somebody just completely destroys what the first person said and comes up with a completely different hypothesis and a completely different prediction. And both of them are very convinced, you know, that they're correct. And both of them are basing their conclusion on the same set of data that was presented. It's all about how, you know, it's perceived, how, you know, they link it, they put it in context, and it's, so at the end, we say, and that's how we write it in our patient management conclusion notes, is that, you know, there were these 3 different opinions, and we will discuss with the patient and, you know, decide what we want to do. In smaller practices, I know a couple of programs that have started using this nomogram, you know, that we developed, and they present that information to the patient. I know Sam Weeb does it in Calgary. When I visited there, he was so proud, you know, his residents were showing me, they had the paper version printed and laminated in their pockets, and they're like, see, you know, it's laminated because we have to erase it afterwards. And I'm like, do you know there is an online version? That would be easier. But I mean, you can do what you want. I think the main challenge with all of these approaches remains that we will not know, you know, if that decision is correct until at least 6 months later. So what we started, so we're talking about it now. I don't know when we will start doing it. Is we will have this sort of how you have an M&M, you know, mortality and morbidity conference for surgical complications. We would have one for epilepsy surgery outcomes, and we would pick a case that was actually operated and, you know, go through the whole presentation and come up with a conclusion, but then show what actually happened and go back and try to dissect the data then, you know, to see what were the clues that we missed. So we're trying to mimic this kind learning environment in a wicked one. I don't know that that's the right way of doing it, but that's what we're talking about here.
Okay. Well, we're looking forward to seeing the results of your research, and congratulations on being a leader on this much-needed research, which will certainly be a game changer in our practice. And thank you very much, and we hope to see you in Washington in a future visit for another talk. Thanks a lot.
Thank you so much for inviting me. This was a pleasure, and I'm so sorry I couldn't be there in person. Thank you.
Thanks. Bye-bye.
Thank you. Bye.